Yes, we are. That's red. Red is record? Oh, well, good. I'm glad y'all knew that one. Okay. Are you sure
guys,
red's
nice to be
recorded?
back. Good to see you. I seem a little fatigued. I have a new baby at home, a new puppy. So, yes, and I forgot what it's like having a baby, but she's awesome. Tonight, we're gonna talk about generalized anxiety disorder. I don't know if you've already read some of it about it in the text or not. So this is kind of an overview, like I did last time, of chapter 2. But I did bring some supplemental material. I brought some case examples we'll do towards the end, and an activity where we'll actually get in groups and do a case conceptualization as well. Okay. All right. Everybody see that all right?
Uh-oh.
Okay. So let's go back. All right. So the core cognitive feature is worry. And additional features are fatigue, restlessness, irritability, muscular tension. As I was preparing this, I was thinking, maybe I have this. I'm kind of achy. Yeah. Clients tend to be worried about a variety of events versus, just one issue. And they feel really ambivalent. They feel the need to, like they need to stop worrying. They usually recognize, that they worry very excessively, but at the same time, they know that it serves a purpose for them as well. Okay. You always want to rule out with a client medical issues that may be causing the generalized anxiety, and this was a learning curve for me as well. It could be due to insomnia, to alcohol and drug use. And this right here too, I didn't even realize that, hyperthyroidism, hypoglycemia, and adrenocortical tumor, HIV. So we would want to go ahead and think about, okay, with each disorder, not just this, how am I going to approach a client, to have them rule this out, medically. You don't want to say, you might have a tumor. Go to see the doctor and then come back and see me. You want to say, this is just a normal part of practice. When we suspect, certain conditions, when was the last time that you had a checkup? I would advise that you do that. Okay. Any questions on description? Diagnosis? Okay. Let's grab this. I actually figured out the animation thing. Okay. All right, lifetime prevalence is between 5.8% and 9%. Greater risk for women, young adults, and blacks. So I thought we'd have a discussion. Why are the above populations, why do you think that we're at greater risk?
More stress.
And what causes that?
Life changes.
Life stressors?
Could be family situations.
Absolutely, family situations.
Like a patriarch or a matriarch dies in the family. That was the person that held everybody together.
Absolutely, that's a good example. That's an excellent example.
Less power, maybe discrimination.
Absolutely, less power, discrimination, all of these stressors, even though we may not always think about them, we have events that happen. For example, I grew up in poverty, and I can still remember lots of situations that caused anxiety. With I call them the hair bow clicks. In high school, you don't have the right clothes, this, that. Luckily, I was a nerd and an athlete, and I was fine, plenty to do. So, but there's lots of risk factors. Young adults, you're just finding your identity. That is a time of anxiety. And you can be discriminated against, by grown-ups, that they, just treat you like a lesser human being. What do you know,
Mm-hmm.
So, anything else we can think of? Those good examples.
Why for women?
A number of things. They could be dealing with pregnancy or babies or wanting to be pregnant or something like that.
I have a question.
Yes.
Is this for America, or are you going beyond that?
That's an excellent question, and I honestly didn't think about that. And the text didn't indicate it, but I would assume it depends on the culture.
Okay.
And even within America, it depends on the culture too, but we are more of that patriarchal society. So I guess it depends really if that culture is more, for example, like Afghanistan. And that's not saying anything negative about that. I'm just saying that culture is more patriarchal too.
Well, just a lot of times I know when we do research, New Zealand or Australia can pop up in there, England, so I just didn't know how broad the research was.
Right, right, and that's an excellent thing to look up. Thank you.
You know, women are more, you know, beside awesome.
Oh, wait a minute.
You know, we tend to really hold things in our heart. We even when we care for our children and our family, we're real maternal. You know, we
And nurturing.
yeah, nurturing. We take a lot of things to heart. So that sometimes it just kind of escalates out. You know, anxiety.
The anxiety,
Yeah.
right, right. We kind of tend to.
And then we do everything. My God.
Multitask. And then there's the guilt thing that most of us, have that sometimes, sorry, Dr. Smith, other genders don't have, yeah. But, so, they can just get up, going about their day, whereas we're thinking, okay, kids have this, for example, my daughter, has dance, you're keeping juggling everybody's schedule in your head, and, and then, okay, what about dinner, and what about, oh yeah, we're out of milk, I have to go to Big Line tonight and get juice boxes for a snack tomorrow, I mean, that's in my head right now, like, if I forget, I'm in trouble. Okay. It's gradual, usually anxious since childhood, usually. That doesn't mean, none of this is cut in stone, Duration prior to treatment, 25 years. 25 years. That's a long time to suffer with something, a long time.
That's from birth to 25?
That's a good question too, and I would say sometimes,
Wow.
because you do see some infants that are more just very anxious. And I always use my own children as examples because I have a lot of them. But my oldest, Ian, he wouldn't mind me sharing this. He, since birth, nobody can hold him but me. Very shy, still has social anxiety. Just stressed very easy. But he's very, on the flip side, very creative, introspective. That's part of his temperament, And so I've kind of seen it, had my own little experiments, I've seen that kind of play out. But I have seen it since birth, in my own children. But so it just depends. Or a life stressor, like you had mentioned earlier, can happen and then it begins. Okay. Can be lifelong. Here's the bad news. Due to chronicity and self-perpetuating qualities and lack of response, it might have a lack of response to treatment. It's really difficult to treat. Really difficult to treat. Their perception of stress and threat can result from their generalized anxiety disorder. So whereas something might happen, can you think of an event, think of something that might not be threatening that someone else might see as threatening. It could be maybe someone walks in the hall and drops a book. Some of you are like, right? And some of you might jump.
Mm-hmm.
That would be one example. They just perceive, or in a relationship, the other person, may just be in a bad mood. They may think, oh, we're gonna break up. It's gloom and doom, right? Whereas the other person just had a bad day. It has nothing to do with them. They just really perceive things in a more negative way. It can subside with age after 50 and be replaced with somatization. I'm sorry. I was gonna say, this is the, my knee, my back, So they, that was really wrong for me to laugh. I'm on my boots. But, so I always wondered, how do you tell? How do you tell? Heritability. I love the butterflies and stuff. I thought it was a bee at first. I was like, I don't get it. Butterfly, bumblebee. It's a bee. Heritability is 30%. So, if you're a neurotic parent, you have a 30% chance of being neurotic as well. So the other traits are neuroticism, nervousness, depression, low frustration and tolerance. So that's where that irritability comes in, and somewhat more inhibitive.
If you have both parents who are neurotic, do you have a 60% chance?
Shut up.
Do you have I don't want to throw down Jason comment on that. That's a good question. 90% have a coexisting condition with the GAD, 90%. Some coexisting conditions are social anxiety, specific phobias, depression, irritable bowel syndrome from that just, being under that constant stress. Personality disorders are the most prevalent. This is not an exhaustive list, but the most prevalent are avoidant, dependent, and OCD, along with the generalized anxiety disorder. 8.5% of people seeing a doctor have it. And you do want to know there's an increased risk of suicide with GED, just so that, if you're suspecting that, you know what questions to ask and just be aware of that. Okay, it's a later onset predicted by, and so they start out with agoraphobia, panic disorder, the specific phobias, dysthymia, major depression or mania, then they may be predisposed to develop generalized anxiety, which makes sense, especially with the agoraphobia. Behavioral treatment options, and I have several listed here. These are also in your text, and this is not an exhaustive list. There's more in your text as well. But just to name a few, the relaxation is really key, because remember it said about the muscle tension was a feature, so and just not being able to deep breathe and just relax, so you definitely want that as part of your treatment plan. Mindfulness is something that's new and more self-awareness for clinicians and teaching clients, so you might want to do some research on that if you were to have one of these clients. The deep breathing, assertiveness, becoming more assertive and seeing anxiety as helpful. Because a lot of them will have, a lot of clients with this will think of everything in global terms. It's like I said before, the gloom and doom, and it's all, my anxiety, and they think that about their anxiety as well. I need to get rid of it. Versus seeing it as, sometimes this can be helpful. Right? The imaginal exposure. I would be careful with that until you were trained. And when you say so, Dr. Insel, because they can have what's called, has anybody ever heard of like an ab reaction at all? Okay. You want to research that and look that up, because when someone has it, you need to be ready.
What is it?
Stay calm. It's an example would be, let's say you're walking them through a fear, okay, like right on the subway, and you're asking them to picture it as if it's happening, and all of a sudden they start choking and just start really, for lack of a better clinical term, just freaking out. They're having a panic attack right in front of you. They're having trouble breathing, and that can happen. Just, as Dr. Ansel has mentioned with the amygdala, you're asking them to trigger these memories. Mm-hmm. They're going to see things, they're going to hear things, or smell things that you're not aware of. It's going to flood back, and some people do fine with that. And that's where you want to use this in tandem. The book doesn't say that, but use it in tandem with the relaxation. Okay, so you're able to remember your breathing, get them to a calm state as they're feeling these intense feelings. And what happens is you'll give them a scale of 1 to 10, and you keep checking in with them. Okay, have them imagine it. Okay, where are you now? Okay, I'm at 8. Do some deep breathing, do something with them, have them do it again. Okay, where are you at? Okay, I'm at a 6. You want to bring them down to a 1.
As a therapist, how do you discern when a client is ready to do something like that?
That's an excellent question. And if you have that rapport and that relationship, the client, everything, and I think Dr. Insel would agree with that. I'm trying to speak for you, but yeah, jump in here if I'm wrong.
Okay.
But everything's client driven, and you're gonna know, and so when you set those goals, you can let them know, okay, that at some point we're going to be doing this, and if they go, no, then you don't do it. You're going to know. You're going to know if when they're ready or not ready. They might be ready at session 2. They might be ready at session 10. So it's different. It's a great question.
I just have to make a comment about the first one where it says reciprocal inhibition, which is where you pair fear with something that's not fearful. And I don't know how many years ago it was, but there was a commercial on television where the child was told to eat a Tootsie Pop and try to cry. And you can't do it. When you eat a Tootsie Pop, you can't cry. So that's what that means.
See my food line tonight. But that's true, and I didn't realize till I read this, I mean, we learned about this a long time ago. I didn't understand that I was using this with some kids that, especially the ones with anger issues, or they get upset very easy. And I'll have the picture, and I got this from a little boy years ago. I tell them to find their own picture of something that's either relaxing or humorous or funny, so that it's the opposite, feeling. I didn't realize that's what that was called. I haven't seen that in a while. And so my one student shared that he imagined his dog, the bicycles they used to have with the big handlebars like that, and he imagined his dog on that bicycle flying over his mailbox. Right? See, that's the reaction I had. I said, can you use that with other kids? He was like, yeah, and then he was so proud because other kids still use that. And that was like 10 years ago, I think, that he came up with that. I use it sometimes, but it is silly, But you can think of something ridiculous and there's no way you can be mad. Have you seen Waterboy?
Yes.
That's a great example, a great example.
I don't know if I should see it or see that.
I watched that over and over and over with my one son that played football. It worked for him. Yeah. Cognitive factors. We have anxiety for a reason. Back in the cave days, we had to really look for environmental threats, in our environment. And this kind of goes into what Dr. Ensler was going to teach about the neuroscience part. Our brain is wired to be defensive, to avoid certain situations. So that anxiety is healthy. I think this is a great thing to share with those clients that think, all of my anxiety is bad. I need to get rid of all of it, and let them know, what, it's there for a reason. And individuals differ, I thought this was key, in their biological predisposition towards their arousal of anxiety symptoms and perception of threat as well. Okay. It's also key to our fight or flight. So it's not always a bad thing. We don't want to be relaxed and never anxious, that could be dangerous. Any questions so far? Once anxiety is aroused, it is increased or maintained by the client's thoughts, by their cognitive distortions. And there's 3 types: distorted, maladaptive, and dysfunctional. I think I have these explained on the next slide. Yes, I was hoping. Yeah. Distorted is, an example of that statement is, something terrible is going to happen. Now you don't know that, but that's what you think. Maladaptive goes back to that I have to get rid of all my anxiety. Dysfunctional, I'm in either complete control or I have no control. Toddlers think this way. They do. If anybody has children who've been around toddlers, they really do. Very dysfunctional. Any questions on these? And this is only one cognitive behavioral model. There's 2 other ones in your book. I just wanted to give you one as an example. And right under Barlow's in your treatment, this is in your treatment book, you have 2 other models as well. I like Barlow's model. He says that GAD's elements of arousal, hypervigilance, and worry is explained by 5 factors, and they kind of interact with each other. Negative events, which you had shared earlier, biological vulnerability or predisposition, your stress response, and your psychological vulnerability, lack of control, predictability, and your presence or lack of coping skills. So all of these interact together. If you lack those coping skills and you are hypervigilant, so you want to pay attention to these things with your client. That'll guide treatment as well. With a lot of, I work with children, and a lot of them just don't have the coping skills. And they've had a lot of traumatic things happen at home, and so they just don't, and they don't feel like they have any control at all. And they'll play things out at school, you know, especially like on the playground, because they just don't know how to react. You know, they'll see, maybe whereas, you know, I might bump into you, and you might be, you know, maybe just do this, and they'll turn around and just, you know, knock the person down. He also has emotion theory. He says anxiety arises from interaction of a heritable vulnerability, the generalized psychological vulnerability where one focuses anxiety on specific objects or situations. You have false alarms, and they're learned through associations with internal or external stimuli. That's kind of with the children at home, kind of what's going on at home. Okay. And it can lead to maladaptive coping. Okay, treatment, relaxation again, coping skills, that CBT, that cognitive restructuring, and mindfulness. Any questions on one of those models? And like I said, there's a couple other models in there too. I just wanted to point out one for you. Put page 174 to 216. We're going to do a case conceptualization. And that I did not put in the PowerPoint a treatment plan, because your book has a great from session 1, beginning to end, treatment plan. What we're going to do, I have a couple cases for you. And before I hand those out, I do want to hand you children and anxiety. I feel, just from my years in working with children, that this is underdiagnosed. What do you think, Dr. Rensor? Very underdiagnosed. I would say.
A lot of times it comes, excuse me,
No, no,
it
no.
comes across as either a behavior disorder or attention deficit, and professionals sometimes don't see it as anxiety. It's to diagnose with a behavioral type of thing.
And it's really sad. I have a case that I've been working with, and the student that has a wonderful temperament, happy, you know, fine, and I keep saying it's anxiety, you know. But it appears as if it's just he doesn't want to listen. Oh, he doesn't want to follow directions, and that's not it at all. He can't sit still. I mean, he really, really can't sit still. You know, he's just, you know, and there's been a lot of life stressors in his life. And so I help him with coping, and he's very brilliant. He knows what to do, but his body, you know, he's just all over the place, you know, and it's pure anxiety. And I can't clinically diagnose in the school setting, but I honestly feel this is what it is with him. You know, this is exactly what it is. Anyway, I have a handout for you about what to look for with anxiety disorder. Then I have 2 case examples here. So what we'll do is, while you're looking over those, and your book will guide you to do your case conceptualization, your treatment book on page 174 to 216.
Do you want them in dyads?
That's what I was just thinking, we'll do
You want
dyads.
to just stay with who you were when you did your beginning activity, so you can work together.
And I would say just pick, there's 2 good cases here, just pick one. One is Trina, a 28-year-old accountant, and one is Donald, a 50-year-old pulp and paper mill employee, and they're very different situations. So I would say just, you know, look over it, look in your book and see which one you would like to do, the case conceptualization. Okay? So you know if there's any questions at all, you can use that. Anyone volunteer to help? Or questions? Or both, you can help hand out and ask me a question.
Jonathan, I think a dyad would just need one of those, the case conceptual, because they'll be working together.
When you have, you were speaking of, people who are predisposed to a certain, I guess,
Temperament.
you know, because you have people that are quiet, and then you have people kind of outgoing, and the outgoing ones, you may be able to see the anxiety sooner or in a greater way. You know, and I'm wondering when they're quiet, you know, kind of reserved, you know, how do you even recognize, you know?
That's a, that,
Yeah.
Yeah.
Go ahead, you go ahead.
Because, you know, it's almost
You can see
Like
some-
the pool. No, we only got.
Right, right, and you don't, some children get overlooked. I think a lot get overlooked, but just because they're quiet and in the corner, you know. But some mannerisms you can see, don't you think?
Well, there's a difference between a child being quiet and shy and withdrawn. Withdrawn is more of a clinical type symptom that you see where they just, you can feel they're just withdrawn.
Right.
And sometimes they actually become mute, which is a way they just totally withdraw from a situation because of the trauma about it.
And some of them actually, I think I've seen where they actually look angry, you know, they look wrong.
If you choose Donald and you need an extra copy, let me know. There's a bottom page to the Donald.
That's about child anxiety. Is that the same thing?
Does everybody have a case study, the case conceptualization, and the GAD with children? Take about, what do you think, 30 minutes? Okay. Take about 30 minutes and then we'll have a discussion.
So this is taking one of the cases basically going through.
Right.
Right.
Yes, just pick one and fill your case conceptualization together and we'll talk about it. And I've got, there's copies for you. This is what I was
I know.
So just have, if you can stop the tape and then you can start again.